So we'll just start off kind of giving the overview of adult learning theory. I think the biggest thing is that there's not a single theory that explains all of learning. So we're going to look at a couple of different things that show us different aspects of learning today, so that we can make kind of intentional decisions about how we teach in the classroom and in the clinical setting. This is a set of principles called andragogy, right? So pedagogy is for kids, andragogy is adult learning theory, and this particular set of principles specifically is for andragogy. And I like this is I think andragogy provides a good overview, right? That these 6 principles show up again and again in other learning theories, but it has limits, and it definitely has its critics. I think one of the big things is that learning. So there's all these principles of learning, right? But this is all situated in the learning climate, right? So there's a context to learning, and then we have to factor in our learners, right? So who our learners are, where they are in their own development also impacts learning. So it ends up being this kind of complex environment, and this is why there's not one model that can summarize all of this. So these are our objectives for today. So I won't kind of berate this, but there's specific things I hope you guys get out of it. Exploring the needs of different learners is what we're going to do on the 26th when we have our medical education panel. And here's how we're going to structure today. I'm going to go through some slides. We're going to talk about some learning theories, and then we'll have some application where we'll shut the computer down and we'll do some small group work. I think we should take a break in the middle, and then again I'll have some slides where we focus more then on the learning environment and the learners themselves. And then once again, we can do application. So we have our 6 principles of andragogy, and they're fairly self-explanatory. So we know that adults become increasingly self-directed as they learn, and that's really good. And I think that's kind of connected with the internally motivated, right? So they do better when the motivation comes from within than when it's coming from an external source. They really change from kind of being subject-centered with kids to being problem-centered, right? They want to be learning through like real-world tasks. So that kind of goes with the authentic task that adults learn better when they can like understand how this relates to the real world, and something that at least emulates, if it's not actually in the clinical environment, that it's emulating the clinical environment. They rely heavily on their prior experience when learning, and they need to know why. Why do I have to learn this? The kind of limitations, though, are that you can see there's nothing about the learning climate in any of these principles. There's nothing about interpersonal interactions, or that kind of social dynamic of the community or of specific interactions that really impact learning. These principles really focus on the learner in isolation. And this doesn't actually describe what the learning process is, right? It's just that if you can kind of like piece together these principles, you're more likely to engage your adult learners. So we do have a theory, though, that kind of looks more at how learning is processed. And this is specifically trying to get to what they call transformative learning, where like a person changes over time through learning experiences. So this looks complicated, but it's not too bad. So we start here, right? We have the learner and who they are in that moment, where they are in their development, and they're superimposed right in the context, which is the world, right? Which is always changing. And so they take their prior experiences, their attitudes, their own personal history with them, and then something happens, right? There's an experience. And the experience causes what we call cognitive dissonance. It jars them in some way. They can't rely on their previous kind of automated responses to deal with the problem. And so in that moment, they have to respond by either feeling, thinking, or doing something. And it may be a combination or any combination of those things. And by going through that process, then they come out changed, right? So they're changed in their self. That could be their identity, their confidence, their self-esteem. Their meaning of the world or events has changed, or they have new knowledge, skills, and attitudes. That's the experience piece that they will take with them into this next learning cycle where they are now changed and slightly different from where they were. So that's kind of an overview of how experience and learning affects the individual. And I think you can see here that learner development is really important in this particular learning theory. We hear experience again, right? So that was one of the principles of andragogy, that experience is key. It's problem focused, right? Like andragogy, that it's relying on this. There's some sort of experience that causes a problem that the learner has to adapt in some way. And I think that this particular theory then also does a better job of incorporating context or the learning environment into it. But this theory doesn't show us exactly how learning happens at like a neuroscience sort of level. So this slide is much more technical, and I'm going to walk you through it. But this is like how learning is actually happening in the brain. So basically, information gets into us through the five senses, right? And so in the setting of a multimedia presentation like a PowerPoint, right, you're getting it through words that I'm saying or words you're reading on the screen and through pictures. And then your brain is already filtering these, right? So like the hum of this projector, right, kind of gets filtered out. If your students are in class and they're, looking at their Facebook page, right, they may be filtering out like your words. So your brain is deciding what's important and what's not at this moment and what can get into the working memory. The working memory ends up being the rate limiting step of learning. This is a pretty important part because this is where knowledge gets organized. So whatever they're taking in has to be organized before it can be stored into long-term memory. So we got our processing and organizing, and then eventually to long-term memory, right? And that's like learned, right? So that's learning. I think that the big thing as a teacher that I take away from this is that we can help with the processing and the organizing so that things get from the working memory. The working memory is really limited, right? You can only fit in there what fits in that box. And if there's too much information to process at one time, then stuff starts getting filtered out. So if we help the learners with the organizing, then we can more quickly move things from working memory to long-term memory, which then opens up working memory for new information. And so this slide is really about how the brain decides what's going to go from working memory into long-term memory. Mm-hmm. And it's basically things have to make sense, right? Be understandable, and things have to have meaning. And so that makes sense. I really think about that as the organized part. If information's well organized, then it makes sense, right? So obviously, if it doesn't make sense and it doesn't have personal meaning, right? No, like that gets filtered out of working memory and you forget it. If it has a lot of personal meaning and it makes sense, obviously, then that's the opposite, and you will have be more likely to move that into long-term storage. But you'll see that you can have learning even when things don't make sense, but they have great personal meaning. And there's a little less, so if things make a lot of sense but doesn't have meaning, you can still have learning. It's just not quite as powerful as having meaning. And so you can bring home that meaning piece by making sure the purpose and the importance of what you're teaching is clear. And again, this gets back to, when it's an authentic real world task, right, then our learners kind of understand, we're going through cases so that they can relate it to patient care and what they'll be doing in the future. And that tends to help it have more meaning. When it comes to organizing knowledge, then, this is what they're trying to do in their long-term memory. So I kind of think of like med students, right, are like here, right? So they can think through things, but only if they go from one logical step to the next, or their knowledge is kind of disconnected, right? So they're not putting it all together, so that clinical reasoning piece isn't happening very clearly because they're just reaching for like random pieces of information. Versus, when you get to somebody who's like out in practice, and you have these much more interconnected. So the more connections you have to a piece of information, the easier it is to recall it later. But this is the kind of stuff we want to help them develop, these organizational structures. And I think it's really interesting that this can be a learned skill. So how information is presented your way and to students, to residents, that's on us, and we can help them then to organize it. All right, already to our first break. Oops, I have this over here. So when it comes to organizing stuff, it helps if I have that information organized in a clear way. And we're going to talk about this more later, but sometimes as a teacher, I just being out in practice for so long, I forget what I knew when I was a med student, it's just, you just forget where they are.
To know your audience.
Right. So you can just end up skipping steps, right? I take too big of a leap and I forget to fill them in about all the little mental steps that have to happen before you actually get to making the diagnosis. And so it's sometimes helpful for me to step back and do what's called a concept map. And so you guys have probably come across these before, but there's a million different ways to do these. So sometimes before I do a lecture, or if I'm going to teach a really complex topic, I will sit down and sketch out a concept map. So these, I think, look more like your kind of traditional concept maps. Mine tend to look like the spider. There's arrows going everywhere as I connect these different ideas together. But I've used these ones specifically in teaching. So the story map, you can see I've written on it about how that could change to be in line with taking an H&P as a way of helping students develop what they need to do, critical thinking, right? The clinical reasoning piece of getting to a diagnosis and being able to think across diagnoses. I've also done the KWL map. I'll do it at the beginning of the lecture. I'll have it on a whiteboard and I'll have the residents say, okay, this is the topic today. What do you know? And we'll kind of list out some stuff. What do you want to know? And they will brainstorm on that. And then I'll do the lecture. And then at the end, we'll fill in the last piece. And I'll have them brainstorm what are the big things that you learned as a way of just kind of helping them process and review and kind of come to those conclusions. Venn diagrams I'm not going to go over. I think the brace maps are very similar to some of these concept maps. So what I'd like you guys to do is to think about a topic you teach, and just in this space back here, start to sketch out, maybe just in 10 minutes, how you might organize it. If there's a particular organizer that you think would be helpful for you in organizing it, and then how you might use it. Is this something that you would share with your students before or after a lecture, or because you guys both teach students, and then how would you use it, and just play around with it for a little bit and get a chance to see what it's like to use these sorts of things, and what problems there are too with using any one of these organizers.
I don't know. The main lecture we teach, they read an article right before they do it.
Yeah. Well, and so
they read.
It may be a totally different organizer for you, Anissa, if it's a journal club thing, is it background, methods, results, discussion, or...
I don't think it's like that. I think it's they read something kind of like a chapter before we have our discussion.
Is this for med ed?
Yeah. So I teach I mean, you know, as a group we teach about the dementia case, but I'm considered like the expert because I'm a geriatrician. So we like divide it all up, and we talk about like dementia and a differential diagnosis and that kind of stuff. So I don't know. But I'm just saying they already know all the answers usually, you know. So.
Yeah, I would just think outside the box, and I know they've been doing that a very specific way for a very long time, and they're a little resistant to changing it. But you know, this isn't you implementing something new. This is just brainstorming. All right, who wants to go first?
I can. We're doing learning about physical exam and the different stages of adulthood: young adulthood, middle, and late. So I did young adulthood, and then underneath that, what immunizations they would need. I would list them, and then the middle adult list what they would need on yearly exams. Then under that would be screenings, all the different cancer screenings for each group, or lab draws like cholesterol. And then under that would be safety and health issues with each one of those groups, and then nutrition and exercise for each one of those groups, and then physical changes in each one of those groups.
Yeah, so I think that's awesome because not only is that like a very organized way for them to be thinking about it, but you've let them know if like when you're doing a preventive visit, essentially, like how can you think through the visit even without an Epic template or your notes? Like if you just know like these big bucket groups, right, then you can approach a well-adult, visit in any situation. That's awesome.
I just broke down
You did the bracket?
Yeah.
Nice.
I think that was probably the best way to do it because that's kind of how we do the lecture.
Yeah.
So I did memory loss, dementia question mark versus delirium. And then for dementia question mark, we usually try to specify, I couldn't think of what the word was, but it should be like no impairment versus impairment. And no impairment usually is a pseudo dementia versus MCI. Impairment is everything else. And then for delirium, try to break it down between metabolic versus drugs and meds.
Yeah.
And then metabolic infection versus intrinsic, like renal or thyroid or B12 or anything. And then the meds, anticholinergic versus like opiates or hypnotic.
Yeah. Can you imagine like writing this up on the whiteboard as you like in that
easier.
Organized way? So the students will be able to follow the discussion easier, right?
Yeah.
I've been to the dementia one, and it probably having you there is better than having had me there. But like it sometimes felt like we were just responding to like whatever the students kind of suggested, and so it was harder to follow like that kind of like this is the organization though that's really behind it. And I can imagine it would be even harder for students, for faculty, it's easier. We kind of know how our things are organized.
Yeah. So
that's cool.
I'll try it next time.
Yeah. Did you guys find any limitations to these? Oversimplification? You need bigger brackets.
There's always going to be little things that are going to fall outside of these topics.
Right.
That don't really are under each of these. So.
And that's one of the important things we have to help teach too, right? Are like the nuances. And so, this is the general thing that you go through, but here's what what are when a kid's behind schedule, now the immunization schedule is different, or you have this abnormal finding on exam, and what are you going to do about it? But they have to almost have these structures in place to be able to understand, like, and this is when you can no longer follow the algorithm, right? So I just pulled up a couple of mine that I've used over the years.
Oh, that looks busy.
Yeah, that is busy.
It is. So this is one of like my grad school course assignments. And so I was trying to come up with a survey. And so I had done this lit search about residents, or I guess it was students too, but of just like self-efficacy and addressing the social determinants of health, because I really think our residents just feel like, oh, it's the black box and like nobody can do anything about this stuff, and like don't even ask the question, like don't open the box. And so I identified then like, okay, well, what goes into like self-efficacy and like feeling like you can actually make a difference? And so the ones that are outlined in yellow are the ones I then constructed survey questions about. So it informed, like, I didn't want to have a huge survey. I wanted like 9 questions at most, plus like one demographic question of like what year of residency are you in. And so that's how I came up with it. Most of the time, I do not make it look pretty. I don't put it in a Word document. Most of the time, how it looks is, where is it? Oh, there it is. It looks like this. So I had a resident where we had like a health disparity like play out on the floor of the hospital, who was having a really hard time dealing with it. I think she thought I was calling her racist, and we had to like debrief multiple times. And it was these very complex conversations, right, where there's a lot of emotions at play. And so it was helpful for me to be like, okay, why do health disparities even happen in the first place? And to kind of go through, and I didn't go through this with her. This was like my pre-meeting, like I just need to like understand why and how these things are interconnected. And this is definitely not a perfect concept map by any means, or comprehensive. But of trying to get to that blue area, that's where I wanted to move her, right? Like, what do we actually do about this stuff as providers? And like, you know, can you take an implicit association test? Can we just, you know, ask these tough questions? Like, you know, the point is that we have to reflect when these things happen. And so, I do think we eventually got there, but
It took a while.
It took a while.
It took a whole map.
It took a whole map, but it was really, I think it was centering for me.
Yeah.
To just have my thoughts organized and to be able to kind of present different. And so then when she would be like, this is all because of the hospital, you know, it was a busy night. Yeah, it was a busy night. You guys had a lot going on. The cardiologist told you that this patient didn't need an intervention, which was wrong. You know, the patient had troponins of 7. Like, that's a heart attack, right? Like, I don't care what the cardiologist said. Like, so there, you know, there were so many factors in it. It was, you know, by the time a medical error happens, it's never one person's fault.
I think what was crazy too, when we were residents, we never trusted anything the ER said.
I
They
know.
trust the ER too much.
It's a hard line to walk though, because I don't want,
You
you
don't
know,
want them
I don't
arguing
want
with
them
them?
arguing with the
Like
ER.
I heard
and
Danka used to do.
well, yeah, I think I had a certain approach to everything, but
I know, but you want them to still just be
I just need them to think critically,
Yeah.
and then when they recognize, well, the troponins are 7, and even though the ER called the cardiologist, and the cardiologist said, well, we'll see him in the morning, that they should recognize that doesn't feel right. I should call and wake up my attending in the middle of the night and be like, should I go ahead and start that heparin drip because this doesn't feel right to me, and to not be like, well, cardiology said this,
Done.
and I'm done. I think that was my bigger point for her. Anyway,
Yeah.
I just wanted to share a couple examples. Do you guys have anything else you want to talk about with the knowledge organizers? I feel okay. You guys are writing a lot and quickly. All right, so now we're going to talk a little bit about hugging and bridging, and then we're going to do another activity. And this is the idea of transferring knowledge, so taking knowledge from one context and applying it in another. And my favorite is inpatient, right, which is where I teach. I also precept in the office. I can't tell you how many times I will have a resident tell me on a patient with diabetes, and I'm like, it sounds like they need to be started on insulin. And the resident will tell me, I've never started insulin on someone before. I'm like, lies! Like, you start
In the
insulin
hospital.
all the time in the hospital,
Yeah.
but they couldn't transfer that knowledge, right? Like,
that
it was
patient.
like they couldn't even access that knowledge and they were like, oh, you're right. And so, which I think is on us then as inpatient teacher. We clearly are not helping them to recognize what they're learning on inpatient and how it's used in the hospital or in the office. So that's the idea of transfer. We're going to take it from one context and apply it to another. It's not usually perfect, right? Like usually you have to do some sort of modification or generalization to be able to have topics change context like that. And it's true, I'm much more cautious in how I ramp up insulin. I'm way more cautious in the office, right, than in the hospital where somebody's going to be in there checking blood
Monitor.
sugar, and
Right.
so if they bottom out, it's going to get caught. You know, I'm way more cautious. So there are usually you have to modify it in some way. But the two main methods that we can, as teachers, help them do this is through the ideas of hugging and bridging. All right, so hugging is teaching the new topic, but you're going to try and put it in as authentic of a future scenario as possible. So you're trying to take what they're learning right now and help them understand how they're going to apply it in the future. Right? That's what we could have been doing on inpatient. You're learning about starting insulin right now. You will need to do this in the office later. It is considered the easier of the two because you can use so many more concrete examples with it. Bridging is a little bit harder. You're going to try and get them to recall their past learning and apply it to what you're discussing right now. So that is a little bit higher level because in general there is some sort of abstraction. They have to take this kind of abstract concept that they've already learned, and then you're asking them to pull it back into their working memory so that you can use it and apply it to what they're learning right now. Does that make sense? Mm-hmm. They're very similar. So I don't know. In my head, I confuse them a lot of times, but I think for our purposes, it's not whether it's bridging or hugging. It's just what are the sorts of activities that we can do to help them do that. So this is just a quick little worksheet from, I should have told you guys this. These worksheets are all from this book, which is the book we read from in my class on, so I take an entire semester course on adult learning theory. This book is not written for medical educators. It's like written for high school teachers mostly, I think. But I think a lot of the concepts are transferable, right, to medical education. So he has given some examples. They are, again, not necessarily, you would have to think through, like, how can this be this sort of, analogy. You'd have to think of your own medical education example, right? Because these examples are quite clearly like secondary education examples. But then there's just a place to brainstorm your own ways. How might you use this in medicine, either in clinical teaching or in the classroom? I think either one. And then there's hugging, and you can see I wrote in the my inpatient example. And again, there's just a spot to brainstorm ideas. Let's just take a couple of minutes and brainstorm. All right, you guys want to talk through some examples?
Sure.
What do you guys have for brainstorming? Do you have activities that you are already doing or ones you would think about doing?
Yeah, I did. So I'm still doing this Alzheimer's lecture because it's like the longest one we do. But just ask about, I have categories for the questions that we ask the families to evaluate for safety, like falls, driving, cooking, wandering, abuse.
Yeah.
That kind of stuff. And then explaining similarities and differences. I just, asked about Alzheimer's and vascular, how they similar, how they different. And then for the other one, the advantages and disadvantages for going to a nursing home versus staying at home, which they probably wouldn't really know the answer to, but we can still talk about it.
Yeah. I don't know. They're only third years, right?
Yeah.
They don't have all the answers. Becky, do you have something that you do for brainstorming?
I didn't really get brainstorming that good, but the analogy I did this is probably brainstorming too. After discussing kidney disease and how it causes hypertension, then make them recall what they've learned in the past or what other diseases may cause hypertension in the patient and have them discuss it. And then I did a different topic for the advantage and disadvantages. I did lower income patients to eat healthier diets. Advantages, of course, decrease healthcare costs, decrease disease, increase self-esteem and decrease obesity, and improve education results. And of course, disadvantages, cost, location to teach these people how to cook, whatever, bake. We need recruitment of stores. That might be a hard process to provide better access to fresh fruits and vegetables, and homeless people may not have the resources to cook or bake in their homes.
Through those barriers, yeah. So one of my favorite brainstorming ones. Sometimes I'll do this at the beginning of a lecture. Mm-hmm. I obviously did not role model it today, but it's called the best worst warm up. So I guess it was last week I was giving a faculty development. Oh no, that was this week. I gave a faculty development on how to make up an effective PowerPoint slide deck to the residency faculty. So the warm-up was tell me about the best PowerPoint presentation you've ever
That's
seen,
cool.
and tell me about the worst. And so then I'm having them recall their prior knowledge, right,
Yeah.
from the long-term storage, and then we're going to build on that during the session. But I think it's just one that like people kind of get into.
Yeah.
Like people like to talk about the best and the worst a
Yeah.
lot. I also wanted to point out that I think doing this chart, is a brainstorming activity, right? Because
Yeah,
you
it
ask the group, and so that's a way to get everybody brainstorming. And then I think for the analogies, when they were talking about similarities and differences, I just think about how much in medicine we teach that's comparing and contrasting, right? So, and he said, I don't know if you'll remember, but I think I was doing this lecture even when you were a resident on pneumonia, and I have this like
Yeah.
huge chart, right? That's like community-acquired pneumonia, hospital or healthcare associated and hospital acquired, and then we talk about which are the pathogens in each one, and so we're like comparing and contrasting, treatments and risk factors and all that kind of stuff as we go through it step by step. But I think there's a lot of that we do in medicine where you're
Yeah.
kind of comparing and contrasting. Or we've had residents who are again struggling with like the clinical reasoning part, and so like I'll sit down with them and we'll talk about shortness of breath, and we're not just going to talk about like PE from top to finish or pneumonia. Instead, we're going to talk about how does each one of these things on the differential present? What labs or what exam findings are you looking for? Like, what are the labs that would differentiate each one of these to try and teach that like horizontal thinking instead of the kind of vertical thinking that at least in medical school I think we're taught a lot. Like, this is PE, and then in a different chapter you have pneumonia. But that's not how patients present, right? Like, they
Right.
present with a symptom that has to be worked out. And then for the advantages and disadvantages, I was wondering about just even, if you're teaching hypertension, to me it sounded like risks and benefits, right? Like, can you give them
Taking your
the med
medicine?
list and be
Yeah.
like, students, tell me, what are the risks and benefits of ACE inhibitors versus hydrochlorothiazide versus calcium channel blockers? And have them think through it that way and make their own chart so that they're comparing and contrasting.
Yeah, that's almost where I went with like medications, like
Right, for Delirium?
supplements like ginkgo and that kind of stuff.
Oh, yeah.
But I was kind of like, that's dumb because ginkgo is stupid, so I'm not gonna entertain that.
I was gonna say it might be helpful, when they can't come up with any advantages. Maybe then they'll understand it's just like risk of bleeding, right? What about for hugging? Was it easier to do
Yeah, I think so.
hugging than to do the transfer?
Oh. The first one?
The first one was the harder one,
Yeah.
right? The first,
Yeah.
or bridging. I'm sorry, and then the hugging was the second one. I don't know what you guys think about simulation. I think we do a lot of simulation in
Yeah.
medicine, right?
Absolutely.
There's a whole sim center, right?
Right, yeah, so I was like, that's what we do in the sim center for this.
Do you guys use role play in your teaching?
I
too?
just did, yeah. We do role playing. We did counseling of a patient. One person had to play a patient, and the other one had to do the counseling of the
Yeah.
education of a certain disease. And they
Yeah.
just had to do it off the top of their head in front of the class.
Woo!
Yeah, they were not happy. They wanted to
That's
use.
high stress.
They wanted their Dynamed out. I was like, no.
Yeah, but yeah, I think Jerry Talk, right, is the program of like talking to older adults, and they make you role play it with a standardized patient in front of everybody, and it's in a very supportive
Yeah, no.
environment. But there's a lot of, I think we do a lot of this in medicine. Or I was even thinking of the SOAP notes, right, that you were grading.
Yeah.
That's a form of role play,
It is,
right?
yeah.
Because the students, we ask the students to see a real patient, but they're writing the SOAP note and turning it into their professor instead of
Like
it
chart.
become a
We do the same thing.
yeah.
The
And so I
exact
think
same thing,
that's a form of simulation,
Yeah.
right?
Yeah, that's what I wrote.
before
Like,
it's part of an actual medical
Right.
record, practice it and get feedback.
That's what we do, yep.
yeah, this was like for me transferring from that initial like, well, what are the dangers of safety? The safety things that we look at, and then just asking questions like, what questions would you ask somebody if you were worried about them driving?
Right.
What questions would you ask if you were worried about whether or not
Yeah.
they're falling? That kind of stuff.
Yeah, that kind of mental practice. I think
Yeah.
questioning's a big one. I don't know. Under mental practice, I also had cases. Like I feel like that's what we're
Oh,
doing
yes,
with cases.
cases. That's
It's
what
a-
I have.
I almost
Yeah.
would consider cases
For
simulations.
all
but,
the thing, yeah.
I mean, to me, I kind of took more of it though from that piece of like interviewing. What do you say when somebody, like, what if somebody does say they're being abused? What if they say they're falling? What are you gonna do?
Right. Yeah.
So-
Planning ahead, right?
Yeah,
Practicing it before you're
Do
actually
you know
in
the
the
number?
situation.
Do you know how to call elder
Yeah.
abuse? Do you know how to call physical therapy?
Yeah, I
like,
think
do you
that's
know who to
perfect.
call? Yeah.
Yeah. And when I have cases, I'll try and structure it like that. Like
Yeah.
I teach a hypothyroidism, so we do,
A case, yeah.
straightforward hypothyroidism and like elderly patients where you have to like reduce the dose, or pregnant patients, right, where the treatment plan is a little bit different too. So that they're working through like every possible scenario, and hopefully then they've mentally practiced it, and now
Right.
when they're in the situation, will they be able to apply that knowledge easier?
Yeah.
What do you guys think about contingency learning? Because I thought that was the harder one to come up with stuff.
I mean, for me, this would be kind of like what we do in the SIM Center, where they go and interview a patient, and then we kind of see, like, well, what'd you guys come up with? Would you, like, and we actually watch them, like, Big Brother situation. Like, how did it go? Like, because it's
Yeah.
really hard for them to tell people, like, they're supposed to go and tell somebody they have dementia. We're like, how many of you just said dementia? How many of you said us? Because the standardized patients are instructed, if they say dementia, sometimes they'll be like, oh, it's just dementia. Oh, God, at least it's not Alzheimer's. And then they got to be like, oh, crap.
That's awesome.
So, that whole, like kind of with the SOAP notes, giving feedback on whatever they went through, whether or not they should ask more questions.
Yeah.
that
Are the
kind of
students
stuff.
able to self-identify? Because I feel like the contingency learning is really helping them grow as self-directed learners,
Yeah.
right? To be able to look at themselves and be like, okay, this did not, disclosing bad news did not go well in this scenario, and I need more practice in this or more
Yeah.
learning in this in order to get better. I feel like we get there in the residency a little bit with like QI of like, by going through the process of QI, at some point, like we have to be like, like
Yeah.
this every time, like there's some problem with the QI project, and of like, well, what do we actually need to proceed? I think EBM too, like just teaching the skill of like looking things up. Sometimes, you can get the learners to self-identify, like, yeah, you need more knowledge in this. How are you going to get there? What resource are you going to use? But I think the idea is to try and help them grow in that kind of self-directed learning. And so, it's great while you're in school, while you're in training, you have all these people around who are going to give you feedback. But ideally, we're training people who have reflective practice and who are good at like thinking about themselves and thinking about how they want to continue to grow as providers. Ideally, right? All right, so I think that's it for the first section. So this is this is Venice, where I was this summer. Beautiful. The Rialto Bridge. So this is our mental break, and I thought we would actually take a break. I know I need to walk around just a little bit. On this half, we're going to talk more about climate and learning development over time. And I think these other two ones, that's what really adds that kind of social and emotional context that I think so complicates learning. And so the course climate or the course environment, that's, the instructor has a role in that, but it's not only the instructor who creates that environment, right? Other learners influence it. And so you can see, at least for me, I had a hard time separating out climate from learner development, because depending on where your learners are, that influences the climate. And I think we see that on inpatient because we have a finite group of learners, but every team is different, and every month on inpatient is different from my experience as faculty because the team dynamics vary so widely. As for the learner development, as an educator, we can't exactly control where our learners are in their development, but we can try and respond by making sure the climate is shaped appropriately for them given where they are. And I think for me, what I really think about, I prize patient-centered care in medicine, and so for me there's a lot of similarity between patient-centered care and learner-centered teaching, and I think that's my approach then to teaching has a lot to do with how I try and set up the learning climate for my learners. So learner development has a lot of different factors, right? And so the book I used was the Ambrose book. There's a whole chapter on climate and development. And so, they break it down into these 3 pieces that kind of go to and move into learner development. It's interesting that, you can have learners from in the same cohort who maybe even had like the same trajectory of like high school, med school, residency, and they can be at completely different stages of development. I would also note that learner development's not always in a forward direction, right? Like people can take steps back in their development. So this is again, there's multiple models about learner development. This is the one that I think makes a lot of sense to me, and I can't tell you how many times I have opened up the Ambrose book to this chapter, and I have this kind of pyramid sketch or stair steps. I have it sketched out in my book because so many times when we're having like professionalism type issues with our learners, it's because our learners aren't where we think they are on this scale. And so we start at the bottom, right? And that's developing competence. So that includes intellectual competence of just being able to problem solve on your own. That includes being able to take care of yourself physically, right? That you're in charge of your own health and well-being. And that includes the interpersonal component of, being able to communicate effectively, potentially, some of the leadership sorts of qualities. And this is the foundation, right? So once you have those competencies, then you have the confidence to be able to tackle new problems and new situations. And then we go to managing emotions, right? And that's kind of this is like the foundational step of emotional intelligence, right? You just like, at first you have to be able to identify your own emotions and communicate those out to others. And then you'll be able to identify and respond to another person's emotions. But I really have had residents who are not cued in to how they are feeling and thus don't know how they're transmitting it to other people.
Especially burnout too. Like a lot of them
think
know
it
that
makes
they're
it hard,
burned out.
right?
A lot of them know that they're burned out, but they don't know how to unburn out.
Yeah, that's a good point. I hadn't thought of that, but maybe burnout forces us to regress.
Yeah.
That might be one of the symptoms. I know from my own burnout, I thought I was keeping it a secret from the learners, Hell no, I wasn't. They
I
called
usually
me
can
on
tell when
that
I'm
stuff.
burned out because usually it means it's time to go on vacation.
Yeah, take it away. Yeah.
It's like, man, I feel like it's another vacation coming up.
Yeah. Yeah, it'll only do you for so long.
I know. You always have to come back. And then sometimes you're more depressed, I think.
So next is developing the autonomy, right? So you're handling problems on your own without the help of your parents or other adults. And there are authors out there who suggest that millennial learners have a harder time with this specifically, that they had parents who have seen them through, and I live on a street in Clifton where it's like every other house is a college professor at UC.
Yeah.
And so sometimes we just all get together and talk and, gather in somebody's yard. All the kids are playing. Literally had college professors tell me that they gave the student a bad grade and a parent called them about it.
In college.
In college, yeah, these are college students, yes. Just like these sorts of things are happening. And so I don't want to have a blanket statement for all millennials, but I think it's something for us to be aware of
well, that's like the young millennials. I'm considered millennial. But I'm not
technically I am too, or barely almost. I'm
I think
1981.
probably border, because I think
Yeah.
it's 1980. I think it's 1981, 1982. Yeah.
It's 1982, yeah, to 2000. It's the
I was born in
millennium.
'84, but it's kind of more.
Yeah, so
Gen
you're
X.
like me. You're like on the cusp, and I tend to have traits of both
Right,
generations.
yeah.
And anyway, those traits of a generation can never, again, it can't be a blanket statement for all people. People can be different.
Yeah. But because the biggest thing about a lot of the kids, it's like the stuff that the environment they're in, but a lot of it has to do with how their parents did. Like I have I have a niece and a nephew that are both Gen Z. Well, they actually both were born in 1999, so they're technically millennials like me.
They're
but
technically
they're like
millennials, but they'll
on the
share
border,
attributes probably.
So, but one of them,
Is Gen Z what they're calling people born after 2000?
they're called
Okay.
because the millennials are really
Would be
called
my
Gen Y.
kids. Yeah.
So Gen X, Gen Y, Gen Z. I don't know what happens after Gen Z. It just explodes. I don't know. Go back to A?
It's,
Gen
al-
A?
it's alpha. Well, that's what they told me. Generation Alpha is
Okay. Go
what
back
the
to
little
A.
ones are right now.
Oh, interesting.
They don't know much about that.
They don't know. Yeah, that's what I've heard is that they won't get their
Characteristics.
yeah, their fun name or
Yeah.
like the pithy name.
Well, that's what they know, because the Gen X, they never got one. It's just Gen X. And so Gen Z, I guess, would be the same.
I don't know. I feel like Gen X is their like kind of pithy name.
Yeah.
Like,
That's what I am, Gen X.
yeah.
We didn't get baby boomer.
Yeah.
That's a cool name.
Millennials. I hate being a millennial, though. It's the worst. That name
Well, I
has
think
a negative
millennials do
connotations.
get. Yes,
They do.
they get like stuck in a box sometimes.
I'd rather be
and-
Gen Y.
And to be fair, like many people will say that every time the older generation is teaching a younger generation, they always find tons of problems with them, right? Like that's
Well, yeah, because the
Part
baby
about it.
boomers had a lot of issues, too.
definitely.
They did all types of drugs. They got Hep C and all that
Yeah,
stuff.
right.
You know?
Yes. Yes, there's Hep C screening just for them.
Yes. It's true.
There was the free love time and all of that. Like, they got
Yeah.
a lot.
But I think so for us as educators, right? It's just thinking about that. Like, are there issues with autonomy? And then you get to the most important step, right? Which is establish identity. And you can't get any of the upper steps until you get this established identity down. So it's considered the pivotal step. It's that development of a clear sense of self. It's being secure in who you are, and that includes everything from like body image, gender, sexual orientation, racial or ethnic history, your own personal history. And it means that if you have a strong sense of identity, the new ideas and the exposures to different beliefs, they're not a threat, right? So for people who don't have that like secure sense of self, when they're exposed to these new things, it feels like a threat to who they are. And so, I don't know, for me, I find that to be a really pivotal one. And again, thinking about the resident who thought I was calling her a racist and all this kind of stuff, of just wondering, like, I mean, she really, she came from an impoverished background. She had this huge imposter syndrome, right? Of like feeling like she was going to be found out, that, you know, that she grew up in a trailer park, and like that this is not the story of most doctors. And I think that she struggled with her self-identity. And so there I was like challenging her with this new situation. And so she really like lashed out at me. And then finally we get to those kind of interpersonal relationships, that, you know, you can have real intimacy, you can have these meaningful and long-term relationships, and you can have more tolerance for differences between groups of people. Developing purpose goes from, you know, that identity is like, I know who I am, and developing purpose is, I know who I'm going to be. And so that's a time of nurturing interests and committing to a profession or a lifestyle, even in the face of adversity. And you would think then that like everyone who's going into the healthcare career, like kind of would have that. I mean, but I think that's not true. And then lastly, you have that integrity stage, balancing self-interest with your social responsibilities, developing a set of internally consistent values to guide you and to guide your behaviors and your choices. And I just wondered if you guys had any examples of interactions with learners where you might see, oh gosh, perhaps this was part of their challenge. Or I can keep giving examples too. I just wasn't sure you guys are tired of hearing me talk.
I don't know about. I think the biggest thing is, like you said, is that, like, because I work with like M1s,
Yeah.
and they're trying to figure out. One of them wants to be ER doctor, so I think that it's easier for me to teach her knowing that. Like, oh, you want to be an ER doctor?
She knows who she wants to be.
Yeah, so it's like, oh, you want to be an
clear.
ER doctor? This is an acute patient. That would be awesome for you to go. You know, or if it's somebody who just came out of the ER, I'd ask them like what their experience was about. Versus the other one that I have, she thinks she might want to do psychiatry. She doesn't know what she really wants to do, and so it's a little bit harder. I know she's interested in psychiatry, so if I have like psychiatry ones, then I'll let her, you know, interview them. But so it's easier to direct them when they have a.
Yeah. I thought the kind of knowing, like committing to a choice in a career or a profession despite adversity and like going after, I thought that was interesting. It made me think about, you know, every year we have applicants to our program who have failed step 1 or step 2 or some combination. And they have to talk about it like during the interview, and it's not everybody who has a failure, but it's really amazing. Those who have had that failure, who have had to stop and consider, sometimes extend medical school, and really think about like,
They need to just leave.
do I
medical
want to
school?
do this?
Yeah.
Like they come across so much more mature.
Yeah. Like, you guys need to.
I love her. I really love her. But yeah, but she and I met, and she spoke
She's
beautifully about what she learned and about
Because
herself.
I did her mock
and-
interview, so I taught her well.
Yeah, no, she did so well. She hasn't interviewed officially with us. I
Oh,
just
she hasn't? Okay.
offered to meet with her as like, hey, do you want an associate program director's perspective on how to interview? So I don't know, and that's not, again, I can't make that blanket statement that everyone who fails step one is a more thoughtful resident, but
It's just, and that's how you really learn about, like, they always say, like, if you go through your whole life and never experience really any adversity, you really never know how you bounce back.
I agree.
yeah,
And
I think
so-
that's
I
true.
agree.
The people who've never had to go through struggle and know how to bounce back.
I don't
It's-
think they're
and
as strong as other people.
No, because they get really frustrated, I feel like, when things aren't going their way, when everything's always been so
Yeah.
perfect.
Or they have to develop that sense
Yeah.
of self later on in life.
Yeah.
Right? They're not getting challenged to develop it. So I just wanted to also briefly talk about how intellectual development occurs specifically, because again, I've just had many scenarios where I've seen this kind of play out. So we start, I guess, let's say secondary education, maybe, high school. There's this kind of duality of knowledge, and it's really concrete thinking. There is a right or a wrong answer to every single question. There's a clear authority who dispenses knowledge, the textbook, the teacher, right? And they can't be wrong. And I think part of this, the students also kind of thinking of themselves as their role is basically to just like regurgitate the information that's been handed down to them, right? So they're not really playing with knowledge. And there's also this assumption that everything that is knowable is already known, right? So it's this very concrete thinking. And so for this group of learners, group discussions where you talk about opinions and perspectives, right? That's not really going to be valued by them because knowledge is concrete and it's black or white. So then students will progress and have this multiplicity of knowledge, right? So they're finally understanding that there's lots of different opinions, but they also feel that all opinions are valid, right? So all these different opinions about what is right and wrong, all these shades of gray are equal in their minds. So they can't really tell how one opinion
Like
or
a devil's
perspective
advocate person.
is
Right.
better than another. I'm not even sure that they can really play devil's advocate because they're all equally valid, right? So
Yeah.
like every choice is valid. And so now teachers have less authority. They're no longer fixated on that right or wrong. And learning now can be made personal, which I think is powerful. But they tend to resist things like evaluations, right? Because evaluations are based on opinions. And that's just your opinion, and I have my own opinion of how I'm doing, and
Yeah.
all opinions are equal. So how can you say that this is the truth of where
Yeah.
I'm at? And I've definitely had students who are like solidly
I feel
there.
like my resident might be in both of those areas.
Yeah, I mean, it's sometimes been surprising to me how far people get in life without having developed some of these skills. So
Yeah, and the other thing that I've learned though too is that there's skills, but there's also just like people's personality types.
Mhm.
Like I did a communication style test, and I found out that I don't know if you ever done one before,
Mhm.
but I'm a DI.
Yeah, I've done that too.
So knowing that, I'm very direct, and that's why I was saying I didn't really want to give my MA that feedback because I know when I come off, I'm gonna come off sounding like a bitch, and I know I'm not, and I know it's not personal.
well, that's specifically a problem for direct communicating females.
Right.
Right. Like direct
Exactly.
communicating males can do
I
it.
know, and that's what frustrates me at times, but I tend to just shy, and that's probably part of the problem is I tend to just leave it alone because
Yeah.
I don't want to come off like that. And so, but knowing that, but I also know that most of the women in my office are kind of the same way. So I don't really have to be that way. I could just tell her.
It's like the OB team.
Right, yeah. So it's not, but it's just rough because I have been in a situation where people have misconstrued
What
me
you're
being
saying.
direct
Yeah.
as a personal attack. And
Yeah.
I'm like, I don't go around trying to personally attack people. Like,
Yeah.
so.
Yeah. So in medicine, I'm an indirect communicator. I'm like total Midwest girl. Like, right, indirect communication is
Yeah.
like what I was brought up in, and
Yeah.
so I will sometimes work with direct communicators, and I do just like it's just been a realization, almost a realization too, that I can give it back
Yeah.
and be equally direct back, and it doesn't upset them.
No.
I'm the same as you, but I respect more people more when they can be direct.
Yeah.
I respect them more. I wish I could be like that,
Yeah.
but I can't. I try. I don't know what it is.
Yeah.
I mean, we are too, but a lot of times, like I said, you have a filter. So in your mind, you're like, oh man, but you're like, but you.
Right. Well, you can
don't-
be direct and respectful, right?
Right. Yeah. Yeah. You can be.
Yeah.
But you, like I said, when you've been kind of like burned and people like I almost quit my job once because people, I like literally was crying, upset that one of my patients couldn't get her insulin, and people were like, "What are you doing? Why are you trying to sabotage us? What are you?" I'm like, "What?" But I guess just people are sensitive and they don't want to look bad. And it was more like they didn't want to look bad in front of everybody.
Mm-hmm.
If I would have said it like pulled them off to the side and not in front of everybody, it wouldn't have been a big deal. Which for me, if you say anything, it doesn't matter who's around. I don't care. Like
Yeah.
I'm just not that kind of person. I'm not easily. I don't know. I guess I just don't take things. I have like a tougher shell, I guess. I don't know. I just don't take things as personal. I could take feedback, and that's what, like, because I remember I used to work in Crossroads with Christy, and she would always be so surprised at how well I could take feedback. And because I guess not everybody can, but it's just.
Nope. They sure can, Anissa.
And yeah, like I said, but I mean, feedback that's specific is fine, but when people say things like, or you're taking too long, you're being slow or whatever, that's just not helpful. Like, I don't consider that to be
It's not
helpful.
constructive.
Yeah, it's not constructive. It's just
Yeah.
like venting.
Yeah.
You know what I mean? So I don't.
Yeah.
That is frustrating.
But
But
I
when
think
people
the-
say specific things, then that doesn't bother me.
The learners who struggle with feedback, which I don't know if you've had that
Oh,
experience.
it's so bad in our class, but we have mostly the 20 range in our class.
Yeah.
And it's all the same. And
Yeah.
they cannot.
Again, I just
They
wonder
cannot.
about that sense of identity.
Right. I don't think they're there. I don't think any of them are there.
And so then you're confronting them with
Yeah.
this. And so we're going to talk more about feedback in a minute, but because I think that is part of course climate and
awful.
course and helping learners develop, right? So let's go back to this really quick. So we've got the relativism of knowledge, right? So finally, opinions are not all equal, that they have to be justified, and that there can be one that is more right. And so they're kind of learning to evaluate then the pros and cons of each opinion. And up until this point, learners really have kind of a quantitative view of knowledge, and this is where they finally get like nuances and the qualitative kind of pieces of knowledge. And so this is really a time of great growth for learners. They can feel empowered, but they can also feel frustrated because now they're finally understanding that like basically all knowledge is incomplete, right? And they understand that not all that is out there is known. And in fact, there's lots of unknowns, and lots of times, especially in medicine, we're operating in the shades of gray. And then the last stage of now that they've evaluated all these different opinions, they're coming to their own perspective of the theories and the knowledge and the opinions and approaches that they want, that is their preferred method. And then this is a time where you can have really nuanced discussions, and they can have nuanced approaches to patient care and approaches to knowledge. So I was going to ask for examples, but I think we'll just move on. So that's kind of what I have for learner development. The learning climate is very similar, right? We've got emotional, social, intellectual, and now we've just also incorporated the physical space that you're in. So there's a lot of overlap. There's a lot of interactions, right? So we have the learner-teacher reactions. We have the peer-to-peer interactions. There are perspectives included in course material, tone set by instructors. We may have reinforcement of stereotypes that creep into what we're teaching. And again, just like each learner can be in a different stage, each learner can experience the learning environment differently, even in like the exact same learning environment. Or they may both find the learning environment positive, but for completely different reasons. So there's lots of ways to kind of consciously try to structure the learning climate. I just jotted down some of them. But again, you'll see that, there's a lot of overlap with andragogy, by making sure they have a clear purpose of like, what is the purpose of this rotation? What is the purpose of this lecture? We talked a little bit about feedback, but having that feedback does set a tone. Again, clear expectations. There's the authentic tasks. When you know your learners and what they're interested in and what their goals are, what their individualized learning plan is, and you can connect the purpose. You can connect these two things, right? A really concrete one is just to use learners' names. And I'm terrible with names, so I just have to like recite it in my head and like use it like repeatedly when I first meet a student. And sometimes on inpatient we have like a first year who'll just rotate with us for one morning, and so I just have to be like, "Hi, Becky. It's so great that you're here, Becky. Becky, why don't I give you a list of patients? And how about Becky, while we're walking to,
So you can
I
remember
just
that name.
use it again and again and again and again."
Yeah, I'm pretty bad at names too. You know who's really good? Schlager. He's so good at that.
He does this. He's the one who taught me how to do this.
Oh, really?
Yeah. You just have to like use it all the time, and
Yeah.
like the first minute or two that you meet the
So
student.
you can just imprint it. That's smart.
It is. It's just unfortunately most of the time what happens, right, is like there's a quick introduction and then people are like moving on to other
Yeah.
things. So I do sometimes have to ask, like when I finally am in a position to like talk to them and be like, "Remind me what your name is." And then I can do it. I don't remember what I was going to say about this. I think I was just linking the learning climate to Maslow's hierarchy of needs.
I was like, I've seen this before.
Yeah. It's a lot of the same stuff, right? So, on inpatient, I kind of just need basic needs met. I need new learners to know where the bathroom is, where to get food, to have protected time to eat lunch each day. And a lot of that, I rely on our resident team leaders to teach the students all that sort of stuff, within the first couple of days of being on inpatient. But they need to know all of that before they can get up here, right, where we are having more interpersonal relationships and then, eventually getting here to self-actualization. So stress in learning. I think sometimes there's like some pushback of like the learning environment is too stressful. But you also don't want the learning environment to be not stressful enough,
Yeah.
right? There's actually kind of a sweet spot there in the
Yeah.
middle.
And I think that's what's hard about, especially a lot of young people, because I remember when I was doing my mock interviews, a lot of the residents, I think I told you this before, they were asking about like wellness programs and stuff. And I'm like, don't ask that. What kind of wellness programs do you offer? I'm like, they're going to lie to you. It's not real. Because I'm like, it's a stressful experience. And you do it for a few years and it's over. Like, obviously you don't want it to be horrible, but you have to know that you're going to experience some stress and there's going to be some level of seriousness.
So the goal is to not
go
go too far on this side of the curve, right?
Yeah.
That if there's too many negative emotions that are triggered, right, then the brain kind of shuts down, the amygdala takes over, it's emotional reactions, and I think that is what we see then in burnout, right, and that kind of regression that we were just talking about in learner development. But you don't want this to be not challenging. And when I was looking at residency programs, there was like a program that was like every Wednesday's off on every rotation so that you can like do dry cleaning and stuff. Isn't that awesome? And I was like, what? There's only 3 years of residency, and you just cut it by a seventh? Like, are you kidding me? So I don't know. Like you don't want it to be not stressful enough. And so I think
it's... you are, I guess, because some people would have thought that was... Because that was how, like...
they definitely saw it as a selling point, and I was like, I'm not ranking you.
Right, yeah. Because I remember, like, Riverside, at OSU, Riverside was like, I don't know what it would be like here, but it was just like, oh, it's so easy. And I was just like, I don't want to go to an easy residency.
I don't want to go to easy.
Yeah.
So, I've definitely had people who are not getting challenged enough, right? And sometimes that's obvious in rounds and that sort of stuff. So it's trying to figure out how do you get them here? How do you provide enough support so they're not like over here? And then I think in the classroom, this is sometimes hard to achieve. But sometimes, it's the quiz, right? Is like what ratchets up at like, there's going to be a role play. Pay attention because you'll be up here in front of everyone. You can kind of ratchet up the stress enough. and find that sweet spot. All right, so I did try to write 3 learning cases. You guys can give me feedback on the cases, because I've never written, I've done lots of patient cases, but I've never written cases about students. But I thought we would just take a little bit of time to work through them, and I don't know how long that will take. If you guys want to try, you think you can get through 5 minutes per case? And then we'll debrief them, and then we'll be done. So in case 1, I gave you 2 different learners. I've had both. We've got the disengaged learner, right, who seems like they're not paying attention. They're on their phone during rounds or, during your small group session. And we've got the student who really seems like they don't have a handle on what's going on, which may or may not be true. What do you guys think?
So student 1 could be bored.
Could be bored.
Just not stimulated enough. And then student 2 just may not be comfortable in the environment of giving the information
Yeah.
that you need. So it could be a lot of other things too, I guess.
Yeah, so I think, definitely with the disengaged learner, asking ourselves, like, are we challenging them, right? Are they on the curve where they're bored? Comes up a lot on rounds, right? Where I have a spectrum of learners.
Yeah.
And so, did I make that? Oh, I did.
Yeah.
And so on rounds, then the challenge, right, is to ask lower order of questions and let the students and the interns answer those. But then to have in my pocket the higher order question that I can ask the senior residents. And again, this is from a book that is not about medical education
Right.
specifically, but when I look at those questions, I think that they are potentially adaptable
To any situation.
to any situation, to medicine specifically. Are there any questions that stick out to you guys that you could see yourselves asking in small group discussions or
Yeah,
in
have we
clinical
left out
setting?
anything important?
Yeah.
Where do we go next?
Yeah, that's a great question
Yeah.
for trainees who are further along, right? Start planning this out. Yeah. What happens at their next visit? How do we get them discharged from the hospital?
What would you have done? Why do you think it's the best choice?
Do we leave anything out?
Yeah, I like that. It kind of flips it on its head, right? And just opens up the possibilities for brainstorming. What aren't we considering? That's great. So the floundering learner, I think there's a potentially, and I feel kind of bad using the term floundering.
I mean, I felt like it was like stressed. Like maybe they didn't respond well by being like called out.
Yeah.
Right. Yes. Did we, in that case, are we like too far, right? And I definitely had students who really want to come to our program, like kind of freak out at first when they're on inpatient, because they just want to impress us, or, Dr. Bernheisel's on certain, and they just want to impress him so badly that then they just can't. They're
Performance
like,
anxiety,
yeah.
eating some propranolol.
Yeah, a little bit. The other thing I'll put out there is that it could be that he's just a slow retriever.
Yeah.
That some people, it takes longer to pull the information out of long-term memory. And so really you have 2 things, right? So the learning process is one process, right? And people can be fast or slow at that. And then the rate of retrieval of things that are already learned can be either fast or slow. So if, like in medicine, so many of us are fast learners, fast retrievers, right? These are the kids who get called gifted and all that kind of stuff. The overachiever or the underachiever is the fast learner. Like, I know you know this, but it's slower to retrieve. And so that's the teacher who feels like a little irritated. Like, why can't you answer this question? Clearly you know this. Your assignments are all so brilliant. And so there's kind of this assumption that they're just not trying hard enough. The overachiever is the slow learner but fast retriever, right? So hand is in the air, they're going to blurt out an answer, but it might be wrong, right? And so it seems like they're trying to like stretch or reach too much. They're trying for something that they cannot do. And then the slow learner, slow retriever, right? They're often referred to as slow learners, or I think there's a lot of names that they get kind of called and that they're kind of labeled as like not able to learn, which is not correct. They're just not able to learn it in the time that we've allotted them. And, you know, in most schools, including I think higher education, we kind of go with like the time allotment is based on the average, right? Like the average amount of time it takes the average student, which is too much time for somebody who's a fast learner and not enough time for someone who's a slower learner and just needs to be processing in their working memory longer than what we're allowing for them.
Yeah, but that labeling can be rough.
Yes.
Because I had a patient who said that she was in, I don't know what they even call it, remedial classes or whatever back then. She's like my age, but she looks super way older than me. But anyway, she was saying that her mom always told her that she wasn't smart and all this sort of stuff.
Yeah, because you get labeled stupid.
Right, yeah. And so then she was trying to reconcile all of that. So she's like, you know, in her 30s now, like me. She's like 2 years older than me. But she had been labeled her whole life as somebody who couldn't learn. So I was talking to her, and she clearly could understand what I was saying.
Yes.
But she was like being kind of borderline. Like she didn't understand what I was saying because people have told me my whole life I'm not smart and I don't know what you're talking about. And I'm like, you know what I'm talking about. Like, like I could tell that she knew what I was talking about, but it was kind of like a defense mechanism.
Yeah.
You know what I mean?
Right. Well, and if we set the bar only this high for people, then they only, you know, like kids especially, right, might only achieve that high.
Yeah.
And that's not.
Because some of the stuff that I was saying wasn't probably above her learning, but the concept of it was you had a messed up childhood, and that's probably really affecting you, and you probably have PTSD, and you need to work with your therapist more and talk to a psychiatrist. But so she tried to tell me, well, I don't understand. I said, well, then you should bring somebody to your appointments with you who could maybe understand better. But I don't trust any, like, you know what I mean? Like she got real borderline. I don't trust anybody. That's not going to work. Like, okay.
So it's hard then for us as teachers to work through that with people. But I think the big thing is that retrieval, we can help students increase their rate of retrieval. Because if knowledge is better organized, it's easier to retrieve. And that's especially when we start looking at what's called the critical attributes. So if you're teaching things that are similar, you look at the deep features, which is these are the ways it's similar and these are the ways that it's different. Because when we store knowledge, lots of times we store it by similarities. But retrieval is based on differences. And so really being able to point out shortness of breath, PE, pneumonia, CHF, pointing out all those differences, right, so that they can more quickly retrieve the information. And so that's our reminder then. Let me see if I had anything else. Nope, that's just everything I just said. But just our reminder of, again, getting back to the knowledge organizers and how we present the information can help them. Because organizing knowledge, again, that's like a learnable thing. Like people can learn how to better organize knowledge in their brains. And we can help them do that. Feedback. What do you guys think about feedback?
I think it's hard.
Yeah.
I think it should be done in a private place, especially if you're going to give constructive criticism.
Yeah.
Instead of being in front of people.
People really don't like it when it's in front of people. There are ways to do that. Jerry Talk is one of those where the way they structure that, because again, you're role playing with a standardized patient, having kind of difficult conversations, and you're in front of your small group, but they really foster the small group first. Like you kind of get to know your small group. The small group participants are asked to identify what you did well, and so they only give you positive. And then they just ask the learner to self-assess what they want to work on. And so it's coming from you, and it's not coming from external, which I think it's a really impressive way to do it.
Yeah, but it's all attending level, and that's what's hard. When you're dealing with learners, you have to have some actual constructive criticism.
Yeah, and so I will often start, again, I work with residents, which is they're a little bit farther along in their training. But I will ask them to self-assess first, because I have so many that are acutely aware of what they're not doing well. And so they'll point it out, and it's easier to have the conversation when they point it out first. But I'm not sure that the guy in our example, right? He's not really there.
No.
Or he or she, I can't remember.
Not going to be there.
what I said. I think I said
She.
she. Yeah. For this one, I just wanted to, have you guys seen this? The kind of steps towards mastery. So this particular student is unconsciously incompetent, right? They don't know what they don't know. They think they're further along than they are. They're completely oblivious to the fact. Then, if we were moving her along, right, she would become consciously incompetent. Oh, I know what I don't know. I know what I need to work on. I know I'm not good at this yet. Then people become consciously competent. So they're good at it. They know they're good at it. And then you get to the unconsciously competent, which I argue is a lot of us teachers. And that's a dangerous place to be too, because you don't know how you're good at it. We lose those steps that we used to know. We used to have to consciously think about, I'm doing these things. I'm continually self-assessing. And that's an easier place to teach from. And so when we're unconsciously competent, I just forget that first year medical students, they don't know what PE is. They don't have the acronyms, the terminology. They haven't done their poem block or whatever it is. And so they're just looking at me with these big eyes. They can't even understand what I'm saying, right? And really even going back to PE stands for this. It is this thing. And this is what, you almost have to go back to the basics.
Because I had an LC group and we were doing an asthma project, so I had to teach them about asthma first. I said, you guys don't know anything about asthma, do you? They're like, nope.
Yeah.
So I had to teach them about asthma.
Yeah, so when they're unconsciously incompetent, right, they don't know that they're not good at this. They do need the feedback, right?
It's dangerous.
You have to give them the feedback. But it needs to be really concrete feedback. Here are the examples of the things that you messed up.
Yeah, that's why
this patient did not have pneumonia.
Right.
This was clearly a CHF exacerbation. Here's why. You did not get to the right diagnosis. This is bad because, and so I kind of think of it as, in the stages of change, they're pre-contemplative, right? And so they just really need very concrete examples. And we've had residents who are like this, sometimes about professionalism issues, they just don't I don't understand, why is it a big deal that I didn't return this page? And you have to concretely it is an expectation of the residency that you will return pages in a prompt manner. Yeah. We consider prompt to be within 5 minutes.
Yeah, you have to say what prompt is.
Yeah. So you really have to break it down concretely, and then to help them to see I want you to be here. You are currently right here. And I think the last piece is so that they don't feel like they're just getting beat down and have no support and you suck, is to work with them of you're here, I want you here, and this is how you will get there. And so here's the first step. I'm going to check in with you in a week, and we're going to do this feedback again.
Exactly.
All right. Did you guys have any other comments about that case?
It says, what concerns do you have about going into feedback?
Yeah.
Sometimes when you are in this kind of situation where you have the unconscious learner, it's just difficult because they can be so close to feedback. But we had this too with a student where he just kept talking and talking and talking instead of asking questions when he was in that simulated, dementia case. And the standardized patients were just so thrown off by the fact that he just
that he talks so much.
Yeah.
Yeah.
Which is not what you're supposed to do.
Yeah. Did he get have a chance to see his own video?
Yeah, that's the thing. I wish they did, because that's the thing. So when they came back and said, well, you didn't really even let us talk, we didn't get to, he was like, no, I got some of the stuff out. And then eventually he was like, yeah, I did talk a lot. So they were all like, yes,
Yeah.
But
It's such
but
a
they
moment
get
for him.
defensive. They get really defensive initially, and then I walked into the room and I was like, no, because I was watching the feedback and I saw him getting defensive with them, so I walked in and I just sat down and listened to what they were talking about, and I was just saying, and so I kind of just tried to be like, well, maybe it was, I felt like he got distracted by the chart, having something in front of him, and he just wanted to read from it.
Yeah.
Maybe as a defense mechanism kind of thing.
Yeah.
So I was just trying to kind of make him more aware of that.
Yeah. I think, I don't know. I think it's easier to give that really hard feedback when you have a personal relationship with the students.
Yeah.
Absolutely.
This is part of the reason why I ended up giving up undergraduate medical education, right? Because I never knew any of the learners in my course,
Yeah.
and it was too hard for them to get feedback, even the sub note feedback, right? Like
Yeah.
they freak out about it,
Yeah.
and like, you guys, this is not a big deal, like.
Right, yeah.
But with the residents, because
you
there's
know.
so few of them, and I get to work with all of them, they generally know that I care about them, and that I'm doing this for their own improvement, right?
Yeah.
And so, in that way, like we are aligned in goals, right? Without me having to explicitly state, I care about you, and I want you to be the kind of doctor that you want to be.
Right, yeah.
But sometimes I think it's helpful to say those things, like.
Yeah.
I'm not here to beat you down. I don't get enjoyment from that.
Yeah.
I'm just saying,
Right, yeah. So
what kind of doctor do you want to be? You want to be
Right,
the kind
yeah.
of doctor who talks over their patients? Or you want to be the kind of doctor that patients feel really respected, and that their opinion matters, and the kind of doctor who's able to get the nuanced history.
Yeah. Yeah.
This is
that's
how you
what-
do that.
Right. And that's what, I mean, I think that he had to take kind of a step back by the fact that I was in there. Like, 'cause I felt like he was kind of arguing with the standardized patients, which was weird, you know?
It's ballsy.
So I kind of walked in and I just, like I said, I really tried not to criticize him because it's like their first day on rotation.
The audio.
So I was just like, I felt like maybe you paid more attention to your papers and that sort of stuff, and you just wanted to get through it. Maybe you were nervous, and he was like, yeah, I mean, I just felt like it wasn't enough time,
Yeah.
and I, you know what I mean?
That's
And
fair.
so,
Videos are such a great thing now when they
Yeah.
get to see themselves. It's
Yeah,
the best teacher
and we've
ever.
had to do that, or we do lots of times. We'll do the audio recordings for patients who have some sort of communication, or sometimes it's the efficiency gap of like,
Yeah.
just record yourself in the office and like, let's figure out why it's taking you so long to gather a history from a patient.
That's what we
and
do
then
with
you
ours.
listen to it and you're like, whoa.
The girl didn't realize that she was taking about 5 minutes when she got in there just to do this and this and look at things, and she didn't even know she was doing all that.
Right.
She was never getting
so
done
you
in
can
time.
kind of like pinpoint that.
she
for
was
them.
doing what?
She
just
was
looking
going
at
and
Organizing her stuff for 5 minutes.
she was like nervous, and then she'd do this again and go over, and then she'd shake the hand and go back over here and look. It was like a nervous thing.
Like OCD?
Yeah,
kinda?
she didn't realize she was even doing it.
I know.
We were like, you spent doing that. Yeah, it was really odd.
Yeah, sometimes those timers too, having them
Yeah.
time how much they're doing, spending on each thing can be helpful. But, yeah, awesome. Well, do you guys have any other questions? Should we wrap up? I feel like we should wrap up.
Sure.
All right.